The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/QZB860. Downloadable slides and practice aids are also available.
Hello, and welcome to Seizing the Day with BTK Inhibitors in CLL, Evidence-Informed Therapy Selection, Safety, and Sequential Care. I'm Dr. Nicole Lamanna from New York Presbyterian Columbia University Medical Center here in New York. I'm pleased to welcome my colleague, Dr. Jennifer Woyak from The Ohio State University. So just as an introduction, obviously, as I said, this symposium is BTK inhibitor focused. So just to review the BTK inhibitor FDA approvals in CLL and non-Hodgkin's lymphoma, as you can see, Ibrutinib being the first to market, which was approved in 2013, has approval in CLL, mantle cell, marginal zone, and Waldenstrom's. Shortly thereafter, Acalabrutinib became approved, and it's approved in CLL as well as mantle cell lymphoma in second-line therapy. And then Zanubrutinib, obviously lots of data coming out, and Zanubrutinib soon to be approved in CLL, but it's approved in mantle cell lymphoma in second-line therapy, and also just recently Waldenstrom's as well. And then shifting focus a little bit on non-covalent BTK inhibitors. This is just the one furthest along in development is Pirtobrutinib, and we'll talk about that later in this session as well. So just to remind everybody about the NCCN guidelines, in patients with treatment-naive CLL that meet indications for treatment, you can see regardless of age or comorbidities, whether they're frail or have no comorbidities, and in patients with mutated TP53 or deletion 17p, you can see Acalabrutinib and Ibrutinib are approved as category 1 agents to use in treatment-naive setting. You could also see venetoclax and obinutuzumab, also category 1. But I think it's just important to note that chemoimmunotherapy is not a category 1 recommendation in any case, and yet we see still lots of usage of chemoimmunotherapy in our patients. And in some of the real-world retrospective data, about 40% of patients who are unmutated IgHV still receive chemoimmunotherapy despite decreased efficacy, and we'll show you some of that data. In the relapse refractory setting, also NCCN guidelines, again, regardless of age or comorbidities, again, in patients with high-risk features such as TP53 and deletion 17p, again, Acalabrutinib, Ibrutinib, category 1, venetoclax, rituximab, category 1 as well. And as I mentioned, when we talk about the different BTK inhibitors, of course, the irreversible covalent BTK inhibitors, both Ibrutinib and the second generation Acalabrutinib and Zanubrutinib, obviously there are differences in potential off-target effects that we see with these agents, and we're going to highlight some of the safety data as well during the symposium. And then, as I said, there are other non-covalent BTK inhibitors that are in development, Pirtobrutinib being furthest along, but you could see that obviously, given some more of the off-target effects that Ibrutinib, for example, may have, this contributes possibly to more of the toxicity events that we see with Ibrutinib when you compare them to other more selective agents. And again, we're going to go over some of this data. And as notable, we're going to talk about the BTK class and the adverse events that are associated with the BTK class that many of us are familiar with. And again, some of the off-target effects with TEC and EGFR are responsible for some of these adverse events that we see with the BTK class. So today's agenda is going to focus on evidence for the use of BTK inhibitors as standard of care in CLL. So we'll talk about some of the key clinical trial data. And then we're going to switch again to talk about case-based discussions and how to put this evidence to work when we manage a variety of different CLL patients, whether it be with comorbidities or prognostic markers or adverse events. So just to move forward, I'm going to hand this over to Dr. Woyak.
Thanks, Dr. Lamanna. So I'll start with a short few slides looking at some of the data we have for BTK inhibitors in CLL. So as Dr. Lamanna mentioned, there are two BTK inhibitors that are approved in CLL, Ibrutinib and Acalabrutinib. And then we also have quite a bit of accumulating data for the other second generation covalent inhibitor, Zanubrutinib. We're going to go through a number of these clinical trials, especially the ones that are furthest along. But just to show you on this slide, that for each of the drugs that is FDA approved, we have a number of phase 3 trials that are showing efficacy in either treatment naive, relapsed refractory CLL. So starting with our treatment-naive CLL data, obviously ibrutinib was the first to be approved in this disease, and as such, we have the longest follow-up from the clinical trials of this drug in CLL. Recently, we saw 7-year follow-up data from the RESONATE-2 trial, which led to the FDA approval of ibrutinib in the frontline setting. This study took patients who were over the age of 65 and randomized them to ibrutinib versus chlorambucil. And we can see sustained progression-free survival advantage to ibrutinib over chlorambucil, as well as overall survival. Benefit was similar for all risk groups, including mutated and unmutated IGHV. And we've seen at over 6 years of follow-up, about 61% of patients remain in remission after treatment with ibrutinib. So Elevate-TN, switching to acalabrutinib, this was the phase 3 study that led to the FDA approval of acalabrutinib with or without the CD20 antibody obinutuzumab in frontline CLL. And here we have 4-year follow-up data. So again, this was a study primarily older patients who are randomized to chlorambucil plus obinutuzumab, acalabrutinib plus obinutuzumab, or acalabrutinib alone. And we can see at 4 years, only 25% of the patients treated with chlorambucil obinutuzumab remain in remission. 78% of those treated with acalabrutinib alone, and 87% of those treated with acalabrutinib plus obinutuzumab. Now, this study was designed to actually compare acalabrutinib plus obinutuzumab to chlorambucil plus obinutuzumab as the primary endpoint, and a key secondary endpoint was acalabrutinib alone versus chlorambucil plus obinutuzumab. All comparisons of acalabrutinib versus acalabrutinib plus obinutuzumab are in a post-hoc exploratory manner. So although it looks like there is a potential advantage to acalabrutinib plus obinutuzumab, the data is not quite as clear as it looks from the progression-free survival curves. And as well, across the phase 3 studies that have been performed, BTK inhibitors show clinical benefits in patients with TP53 mutated or 17p deleted CLL, so anything that disrupts the TP53 gene. Here we have some of the phase 3 trials of ibrutinib, the Alliance and Illuminate study. Alliance was bendamustine rituximab versus ibrutinib alone versus ibrutinib rituximab in older patients. And 24-month progression-free survival for ibrutinib treated patients was 75%. Illuminate was ibrutinib plus obinutuzumab versus chlorambucil plus obinutuzumab, and the median progression-free survival for those patients with TP53 alterations was not yet reached. Elevate-TN also included patients who had TP53 abnormalities, and 24-month progression-free survival was 95% for those patients who were treated with acalabrutinib plus obinutuzumab, and this was similar to those patients who did not have TP53 abnormalities. Now, moving into a couple of the relapsed refractory studies. So this is the phase 3 RESONATE trial, which led to the initial FDA approval of ibrutinib in relapsed refractory CLL. We can see in this population, ibrutinib has a median progression-free survival of 44 months, median overall survival of 67 months. And progression-free survival obviously is much superior for ibrutinib versus ofatumumab. And then the phase 3 ASCEND study led to the FDA approval of acalabrutinib in the relapsed refractory setting. And this was acalabrutinib versus either bendamustine rituximab or idelalisib rituximab. The idelalisib rituximab and bendamustine rituximab arms were similar with a median PFS of 16.8 months, median PFS not yet reached with acalabrutinib. So with that, I'll turn it back over to Dr. Lamanna to talk more about safety.
Thank you, Jennifer, for presenting some of that data. And I think it really sets the stage for why BTK inhibitors have done so well in the treatment of our CLL patients, whether it be if they have an unmutated IGHV or a TP53 disruption. I think clearly the data is very strong, and we now have some really nice long-term follow-up. So in general, when we talk about the safety data with BTK inhibitors, we're obviously, as a class, there have been many common toxicities that many of us are familiar with that we deal with the BTK inhibitors. And common toxicities include the cardiac toxicities such as atrial fibrillation, arthralgias, infection, although we're used to dealing with infections in our CLL patients, whether it be in frontline or in the relapse setting, some GI toxicities such as diarrhea, hypertension, and then some bleeding issues, although mostly, thankfully, minor bleeding issues. But there's also some other toxicities that patient experience, some dermatologic changes such as pitting in the nails. Fatigue can be an issue with some of our patients if we don't think that they're fatigued due to other reasons or due to the disease or something else. Sometimes this can be debilitating and cause a reason to stop therapy or dose reduction. And then the cardiac toxicities are not all atrial fibrillation. There can be rare ventricular arrhythmia events as well. And then cytopenias sometimes happen, particularly neutropenia and some thrombocytopenia that sometimes require dose reduction or holding. And again, you have for BTK safety, there is download. Remember, the practice aid is able to be downloaded for this topic and other topics, just to remind you. So in terms of some of the adverse events that we see with ibrutinib from some of the landmark studies, here is a slide just looking at some of the more key Resonate, Resonate-2, Illuminate, Alliance, and ECOG. So these are all ibrutinib-based studies, and you can see the adverse events that we were talking about with the BTK inhibitors in general: arthralgias, AFib, hematologic, hypertension, bleeding, hemorrhage, and infection. And the D superscript, just remind you that these are grade greater than 3 or higher. So you can see the percentages with regards to some of the ibrutinib-based trials noted here. And then subsequently, these are some of the trials with the second generation BTK inhibitors, acalabrutinib and zanubrutinib. And you can see on the whole, superscript D, so grade 3 or higher, just to call your attention, appears on the whole to be decreased. Again, non-comparative studies, but just to compare to ibrutinib, which was first to market. So when we talk about some of the safety monitoring approaches with some of these adverse events that we see with patients with BTK inhibitors, when we talk about anticoagulation, we try not to administer warfarin concomitantly with the BTK inhibitors. And this in part was from some of the original ibrutinib-based studies that had some, notably on patients who were on warfarin, they had some hemorrhage, and so that CNS hemorrhage, and so that was notable. If somebody develops atrial fibrillation, we would try to consider non-warfarin anticoagulation. And of course, for those patients who develop atrial fibrillation, manage the cardiac arrhythmia appropriately with a cardiologist, treat appropriately. There are medication interactions that need to be taken into consideration as well with the BTK inhibitors. Hypertension, given that our patient population generally is older, some patients have hypertension pre-existing prior to starting a BTK inhibitor, and certainly you want to pull in, whether it be their general practitioner, their internist, or cardiologist, whoever's managing and monitoring their hypertension. Obviously, if their drugs need to be tweaked accordingly during therapy, that would be important, obviously, to keep on top of hypertension. And of course, when we discuss bleeding issues, certainly the majority of this is minor petechiae and bruising, but certainly you want to counsel your patients because they might be rightfully concerned about this, and certainly that doesn't necessitate stoppage of the therapy, but you want to counsel them, and if they're having any elective surgical procedures, you're going to counsel them about when to stop their BTK inhibitor accordingly. Arthralgias can be a little bit more challenging. Most of the time, if it's during initial startage of therapy, usually this can wane over time. However, there are some people where this can be certainly limiting, and we've tried lots of different supportive care mechanisms, whether it be an anti-inflammatory agent, sometimes a brief course of corticosteroids or other, but certainly those drugs may have issues in and of themselves because they might have bleeding potential, affect renal function, so on and so forth. So you have to, it's something that you have to try to manage supportively, and some patients unfortunately might need some dose reductions, holding, or change of therapy, and we'll talk about that. And of course, monitoring for infections and secondary malignancies. This again is part and parcel, I think, what we normally do with CLL patients. But again, some of the trials initially with ibrutinib noted some atypical infections and fungal infections. So we do need to keep an eye on infections, and of course, screening for secondary malignancies. And then just to shift a little bit, because acalabrutinib has a slightly different one of the adverse events that we see initially with initiating acalabrutinib can be dealt with headaches. And certainly this is usually something that is not typically something that's dose limiting, and can be usually resolves quite quickly in a matter of a week, a couple of weeks to a month or two after initiating therapy, and can be usually managed with acetaminophen and caffeine intake. It is rare to have somebody stop therapy due to headaches. And another, we know that there can be some myelosuppression, as I noted with the BTK inhibitors, more particularly neutropenia with zanubrutinib. So this just needs to be kept in mind. Again, sometimes you can see some neutropenia or thrombocytopenia with BTK inhibitors, and you might need to dose reduced or use growth factor support depending. So I'm going to switch to Jennifer to talk about some of the head-to-head data.
Thanks, Nicole. So one of the pieces of data that's been most exciting this year has been 2 head-to-head studies of second-generation BTK inhibitors versus ibrutinib. Both of these studies were performed in the relapsed refractory CLL setting. So the first one of these is the Elevate-RR study. So this study randomized patients with high risk relapsed refractory CLL, and high risk was defined as deletion 17p or deletion 11q, even though now we know that deletion 11q isn't a high risk marker with BTK inhibitors. We did not know that at the time that the study was started. Patients were randomized 1-to-1 to the 2 different treatment regimens with the primary endpoint of progression-free survival. And this was actually designed as a non-inferiority study for acalabrutinib versus ibrutinib. Secondary endpoints were looking at a number of toxicities that were looked at in a hierarchical manner, including atrial fibrillation, infection, Richter's transformation, and then overall survival. So the primary endpoint of non-inferiority of acalabrutinib to ibrutinib was met, and you can see these Kaplan-Meier curves are completely superimposable, suggesting that the efficacy of these 2 agents is the same or fairly similar. Importantly, though, they did see evidence of lower toxicity pretty much across the board with acalabrutinib versus ibrutinib. We'll go through some of the most important ones in particular. So atrial fibrillation or flutter was significantly lower with acalabrutinib than ibrutinib. So 9.4% for those patients treated with acalabrutinib versus 16% for those treated with ibrutinib. This is probably even a little bit higher with acalabrutinib than we all expected to see. One of the things is there were patients who went on to the study that had a history of atrial fibrillation. And when you take into account the patients who are having a first episode of atrial fibrillation, it actually was a little bit more difference between these 2 drugs. And in the acalabrutinib arm, none of the episodes of AFib led to discontinuation, whereas it did 17% of the time with ibrutinib. It's hard to know whether that was just investigator discretion, though. We also saw that hypertension was significantly lower with acalabrutinib, 9.4% any grade versus 23.2% any grade with ibrutinib. Bleeding events, including both bruising and major bleeding events, was also lower with acalabrutinib, 38% versus 51%. Notably, though, this was primarily a difference seen in low-grade bruising, so major bleeding events were fairly similar between the 2 arms. We also didn't see a difference in the rate of infection between acalabrutinib and ibrutinib. Pneumonitis was low in both arms, potentially a little bit lower with acalabrutinib numerically, 2.6% versus 6.5%. Secondary primary malignancies were 9% with acalabrutinib, 7.6% with ibrutinib. And then we saw that these toxicities that tend to continue to occur over time that can be usually low grade, but difficult to tolerate if somebody is taking a drug for years and years, things like diarrhea and arthralgia. Diarrhea did seem to be quite a bit lower with with acalabrutinib than ibrutinib. Arthralgia also early on was lower with acalabrutinib than ibrutinib. It looks like the curves kind of cross when you look at later time points, so not a lot of patients there. And I would argue that most of the patients on the study probably had some episode of arthralgia, whether it's drug related or not, during 4+ years of follow-up. The other study that looked at head-to-head BTK inhibitors was the Alpine Trial, and this was a study of zanubrutinib versus ibrutinib, again, relapsed refractory CLL. And the primary endpoint of this study was a little bit different. It was overall response rate, looking for non-inferiority or superiority of zanubrutinib. Secondary endpoints were progression-free survival, duration of response, overall survival, and safety. So the results of the study so far showed that there was a superior overall response rate of zanubrutinib versus ibrutinib This is primarily due to a lower rate of PRLs, or PR with lymphocytosis, during the time that the data was collected for. It's really important to note that this is a very early study. So you see at the x-axis of these Kaplan-Meier curves, where on most of the other ones we've been looking at, we're kind of measuring in the order of years, up to 5 years at the bottom. Here, the longest follow-up is 18 months, and that's only for a few patients. So the 12-month progression-free survival, 12-month event-free survival, was 95% with zanubrutinib versus 84% with ibrutinib, meeting their criteria for a progression-free survival advantage for zanubrutinib versus ibrutinib. But it'll be really important to see how these data look over the long term, whether this difference is maintained or whether with longer follow-up they get closer together. And as well, this study also showed lower rates of atrial fibrillation with zanubrutinib compared with ibrutinib. The incidence was 2.5% with zanubrutinib compared with 10.1% with ibrutinib, again, with fairly limited follow-up. So I'll turn it back over to Nicole to talk about some of the sequential approaches with BTK inhibitors.
Thanks, Jennifer. So I think we have some now more randomized data really showing that the second generation BTK appear to have less side effects than ibrutinib, although statistically significantly different seem to be atrial fibrillation, the cardiac issues, but we'll see over time, but it seems like a decreased frequency overall of some of the other adverse events that we see with this class. And it'll be nice to see over time whether or not the response rate with zanubrutinib versus ibrutinib hold up over time, as you noted. So looking at sequential approaches with BTK inhibitors, we have some retrospective data. We call this real world data, but just look at this as large data sets, again, retrospective, to evaluate large number of patients who have been treated predominantly with ibrutinib being the first to market. And we have a very large series by the US, and a very large series by the Danish as well. And so over time, it was noted that many of the reasons that patients discontinued BTK or ibrutinib-based therapy really had to do not so much necessarily with progressive disease, but many of them had to do with some of these adverse events that we just discussed. And you could see here about half of the reasons for discontinuation were due to adverse events, and the majority of those being usually in the first year, 6 months of therapy. Now, besides adverse events that we're dealing with and trying to learn how to manage, another reason that with long-term follow-up, as Jennifer noted, now we have patients who have been on BTK inhibitors 4, 6, 7, 8 years from some of the initial studies. And now we're starting to see resistance develop in some of these individuals. And actually, Jennifer presented this data several times, looking at some of the resistant mutations that we're now being able to identify in patients on ibrutinib or BTK inhibitors. So the most common being a BTK C481S mutation. Others can have a PLC gamma 2 mutation. Some people have one or either of these or both of these, and a small subset of patients may have neither of these. But certainly we're now able to identify certain resistant mutations that patients are developing on covalent BTK inhibitors. One of the studies that there have been several studies looking at patients who are intolerant to ibrutinib. And again, remember, most of this data is in the setting that ibrutinib was first to market and then became the second generation BTK inhibitors. And so we have several studies looking at, well, if patients are intolerant to a BTK inhibitor, can they be transitioned on to another second generation BTK inhibitor, i.e. acalabrutinib and zanubrutinib? And this is a nice study presented by the Ohio State group, looking at the use of acalabrutinib in patients who became intolerant or had an adverse event on ibrutinib. And you can see here that they've maintained their response to therapy, which I think is very important. So again, patients are intolerant and not resistant. But you can see for the patients who developed some sort of ibrutinib intolerance, that you can see here that when they were transitioned onto acalabrutinib, that many of them had a lower grade, or a few had the same grade. None had a higher grade of the adverse event that they experienced when they were on ibrutinib. So just some data suggesting that patients who develop an adverse event, that you could still maximize the potential of a BTK inhibitor, and they can be transitioned to another BTK inhibitor such as acalabrutinib. And similarly, we have data, although a little bit more immature, regarding zanubrutinib in patients who developed an intolerance either to ibrutinib or or even acalabrutinib. And you could see here that the majority of patients did not have their adverse event reoccur when they were rechallenged with zanubrutinib. Some recurred, but at lower grade compared to their prior BTK inhibitor. So again, some data that will suggest that you can still maximize the efficacy of the class, even if they have an intolerance. And certainly, I think that's really important to try to do so when we think about our patients long term. And then, of course, switching gears to non-covalent BTK inhibitors, and here is pirtobrutinib, or formerly LOXO-305. Here's a non-covalent BTK inhibitor that doesn't bind to C481S and can overcome some of the BTK resistant mutations that are developing in the patients on covalent BTK inhibitors. And this was nice data that was presented at ASH and more recently at the more recent congresses looking at pirtobrutinib in CLL. And you can see in this patient population that many of them had discontinued for progression. Some of them had discontinued for toxicity, but in terms of progression, the prior BTK resistance was more than half of the patients on this study. Some of them even had prior Bcl2 inhibitor-based therapy with venetoclax, and yet you can see the overall response in this sort of BTK resistant, perhaps even Bcl2 resistant patient population was about 60%. Again, young data, but encouraging to note that we might have another agent that we can use for patients who are having progression and developing resistant mutations on a covalent BTK inhibitor. Here are the side effects of pirtobrutinib. Again, encouraging to see that not any new side effects due to the BTK class overall, similar adverse events that we see with BTK inhibitors, but mostly grade 1, grade 2, very few grade 3, grade 4 events. So encouraging, more immature data, but very encouraging data with a decreased frequency of the adverse events that we typically see with BTK inhibitors. And then I think it's important to note that obviously for ibrutinib and BTK inhibitors, for patients who become refractory, obviously we have some new exciting data with the non-covalent BTK inhibitors such as pirtobrutinib, but certainly I think most of our data really stems from the use of venetoclax in this setting. And so obviously we didn't have many of the second generation or even the non-covalent BTK inhibitors, but when patients became refractory to ibrutinib, we have much more data that's mature with the use of venetoclax in this setting. And so here's one of the original studies looking at a very heavily pretreated patient population. A median number of prior therapies was 4. And in this heavily pretreated group, patients who receive venetoclax, you can see an overall response in this setting was 70%. Now, what we have now is, obviously emerging data with how to use these drugs. And certainly post-venetoclax use, what about patients who might receive venetoclax in the frontline setting? And if they're BTK naive, then upon relapse, can you challenge them or treat them with a BTK inhibitor? And this is data that suggests that you certainly can do so. I think we have other data, such as the Mrd study as well, that also solidifies this type of data, where certainly if you're BTK naive and you've received venetoclax and need therapy, you can see you have durable responses here on the left-hand side. Certainly, however, let's say that you've been already BTK exposed, and so you already have resistance to a BTK inhibitor. And I think that here the data suggests that using a BTK inhibitor is not as well in this setting, and so not as effective. And so we would look to an alternative class or an alternative agent to do so, to salvage these patients who might have developed BTK resistance. So as I noted, the Mrd study came after some of that initial work that was shown with venetoclax in heavily pretreated patients. And so this is the use of venetoclax and rituximab versus bendamustine rituximab in previously treated CLL patients. And certainly, I think obviously we have now about 5 years cumulative data with this study, which is very nice. And so certainly patients who were previously treated can go on to receive time-limited therapy with venetoclax rituximab, which is 2 years in duration, and do very, very well. I think we have some nice follow-up. So then what happens after that? So if patients then relapse, and we do have some patients that now have started to relapse after stopping therapy with venetoclax and rituximab and then being observed and then eventually having progressive disease. So in that situation, you could see here when we talk about subsequent therapies, a proportion of them who were on the ven rituximab arm, about 27%, went on to receive a BTK inhibitor. And then of those in the bendamustine rituximab arm, which were more patients who eventually went on to progress, 59%, if they went on to a BTK inhibitor-based therapy, the responses you can see are on the right-hand side. So again, those who went on to therapy did very well with BTK inhibitor-based therapy, whether they were in the ven retux arm or the bendamustine rituximab arm. So I think it's encouraging to note that depending upon what therapy somebody might has had of prior therapy, that you can certainly sequence these agents in different ways, one after the other or vice versa. So I think in preparation, because we're going to now talk about some specific cases and utilize all this information and data that we just presented, obviously we know that BTK inhibitors are very effective therapies, whether it be as single agents or in combination with monoclonal CD20 antibodies. Jennifer showed some nice data with obinutuzumab, and we'll talk about this in some of the cases. Second generation BTK inhibitors appear to be equally effective as ibrutinib, and again, Jennifer showed that head-to-head data comparison with more favorable safety profiles. And then optimal sequencing of BTK inhibitors and Bcl2 inhibitors is not entirely clear, in the sense that we obviously have very good data as BTK inhibitors are used up front. And then we also have the CLL14 data with venetoclax obinutuzumab, which is also frontline therapy for our older patients with CLL. And that also has been very effective therapy as well. We've shown data that you can sequence. If you haven't had one, you can go to the other and vice versa. So at least now we have emergent data that you can safely go from one to the other. But whether one preferentially should be started before another, we still remain to be seen. And we'll get more data with that with future clinical trials. So let's talk about, we're going to, again, sort of switch our discussion more to using cases and looking at principles for safe and effective management. So let's talk about Nathan, because we're going to talk about Nathan a lot and talk about him in different ways. So here is Nathan. He is 73 years old. Here his white count is 245, his hemoglobin is 10.8, and his platelet count is 72,000, so some mild anemia and thrombocytopenia. He has some lymphadenopathy, abdominal lymphadenopathy, max about 4 centimeters, and some splenomegaly. ECOG performance status 0 to 1, his creatinine clearance is 53. He has hypertension that is well controlled. He has an unmutated IgHV. He does not have a TP53 mutation or a deletion 17p. So when we think about treating Nathan in his current characteristics that we have here, what are potential options of therapy? Would it be a single agent BTK inhibitor? If so, which one, ibrutinib or acalabrutinib? Could we give him fixed duration venetoclax obinutuzumab? Is chemoimmunotherapy still even an option for this patient? Jennifer, you and I are gonna bounce off these cases together. What do you think about Nathan?
So I think this is kind of our prototypical CLL patient that we see who needs therapy. So a little bit older, unmutated IgHV, no TP53 abnormalities, and good performance status. I think this is by far the longest conversation that we have with patients in clinic. And it gets longer by the day as we have more and more options available. So I think, the short answer is almost any therapy is appropriate for Nathan, in my opinion. So certainly he would do really well with a single agent BTK inhibitor. We just saw all of that data with both ibrutinib and acalabrutinib in this setting. He also is really the type of patient who was on the CLL14 study where we saw the advantage to venetoclax plus obinutuzumab. To me, it comes down a lot to looking at safety of these agents and kind of the pros and cons of the administration schedules, because he doesn't really have any contraindications to either of those targeted therapy paradigms. I would say he is not a good candidate for chemoimmunotherapy, especially having unmutated IgHV. We know from many, many studies now that targeted therapies are better than chemoimmunotherapy for these type of patients. How would you treat him?
No, fair enough. I think that is absolutely the exact way I would approach this as well. And you're right, the conversations go indefinitely much longer. I think we always talking about to at least start when you have this many options, whether they prefer fixed duration versus chronic continuous monotherapy, and then after you kind of have their sense of what their preference would be from that end, then you can decide if it's one BTK inhibitor over another. Whether it's once a day, twice a day, or other particular issues about side effects or so on and so forth. So just to summarize for sure, I think we said that multiple options could absolutely be considered for Nathan, given his characteristics in this particular case. And we both agree, I think no role for chemoimmunotherapy, given the data that we have with unmutated IgHV in some of the randomized studies with regards to chemoimmunotherapy versus novel agents in this scenario. And here are some of, oh yeah, go ahead.
Oh, I was going to say, I do think, everybody's practice is a little bit different, and you kind of approach that like fixed duration versus continuous discussion a little bit differently. To me, the way that I always approach it with patients is, with a continuous BTK inhibitor, you're going to have to be on it for an unknown amount of time. We have to at least entertain the possibility that you could be on it the rest of your life. Hopefully that won't be the case, because we may have other options in the future that could limit it. But right now, that has to be the plan. But it's really easy to start. So it's just going to get mailed to your house. You need to come for your clinic visits. There's no infusions. There's no hospitalizations. And then the alternative to that, you have this fixed duration therapy. So after a year, you're done, but it is quite a bit more labor intensive upfront. And I think also just the status of the world makes a difference. And I don't know about you, but I think especially in the times of the pandemic, it is appealing for patients to do the continuous BTK inhibitor where they don't have to come for the infusions. You can actually do some of your visits via telemedicine. I think that those are really patient-friendly options right now.
Yeah, absolutely. And I think we're going to get to this because I know that this was one of the posed questions that we received. Certainly, I think depending upon where you are and what your setting is with regards to COVID, you might amend these recommendations accordingly. Remember, sometimes given the risk features, like this patient Nathan has a white count of 245. So depending, you might be admitting them if you're just choosing fixed duration, you might admit them for their then ramp up or for their first obinutuzumab, depending. And so, those kind of considerations of hospital admission, COVID circumstances may change what you might recommend to the patient, or you're going to certainly have a full discussion about those potential challenges. And certainly we know that even though much appeal for fixed duration for sure, there is more labor intensive or more work. And so depending upon the patient, their ability to get back and forth, ease of monitoring their tumor lysis may also influence their decision or your decision together, depending upon those circumstances. So absolutely, Jennifer, completely agreed. So some of the data just to support Nathan under these circumstances, right? Well-controlled hypertension, were some of the data with the Ibrutinib from the Alliance trial, the Elevate-TN for acalabrutinib, and then again, CLL14 with venetoclax obinutuzumab. So let's go on to case 2.
All right, so let's change it just a little bit. So Nathan's still 73 years of age. His blood counts are all the same, still has a maximum 4-centimeter lymph nodes and a good performance status. This time he still has hypertension, unmutated IgHV. However, now he has a TP53 mutation on NGS. So Nicole, how would that change your discussion and how you might counsel him in first-line therapy?
Yeah, absolutely. So I'm much more comfortable in this circumstance, obviously recommending a BTK inhibitor as chronic continuous therapy. It's not to say that the fixed duration therapy with venetoclax obinutuzumab isn't a potential option, but we have less data, less mature data, not as robust data in this setting with patients with TP53 mutation. So I typically will recommend a BTK inhibitor in this setting until we have more data.
Yeah, I completely agree. As we're getting more long-term follow-up data with the BTK inhibitors, though in the relapse setting, patients with 17p deletion and TP53 mutations seem to do worse. In the frontline setting, there doesn't appear to be a lot of difference in outcome whether patients have a TP53 abnormality or not, which is really interesting and probably says something about the biology of the disease at that point. But and that's in contrast with venetoclax obin, where we really don't have a lot of data that that combination is as effective as what we expect to see with the BTK inhibitors there.
Agreed.
So again, obviously no role for chemoimmunotherapy for somebody with a TP53 abnormality. Oh, and then, yeah, so a good question here is, would you consider adding a CD20 antibody? If you're going to use a BTK inhibitor alone, I think it's really tempting to do that. You think adding another drug to somebody with high-risk disease is going to be beneficial. Although the follow-up we have so far in the Elevate-TN study, for the patients with TP53 abnormalities, the PFS is actually identical, whether they're on Oben in combination with acalabrutinib or acalabrutinib alone, which is different than like the whole trial population. So it doesn't seem that adding a CD20 antibody is going to be beneficial in those patients. Again, supporting evidence, we talked about this a little bit before, but Alliance and Illuminate both included patients with 17p deletion or TP53 mutation, and outcomes were fairly similar to those patients without those abnormalities. Elevate-TN as well looked like things were fairly similar in terms of the short-term PFS for those patients with TP53 abnormalities. So I'll turn it back over to you for the next case.
Yeah. And we could talk a little bit, of course, when we talk about the CD20 monoclonal antibodies with the BTK inhibitors, of course, it seemed that studies, our bigger studies, the randomization of IR versus I versus BR, right? So the Alliance study or MD Anderson data, it didn't appear that rituximab added much to ibrutinib. Obviously, it's very interesting to see the Elevate-TN studies and the obinutuzumab, as you noted. I think we always get asked, whether there's a benefit of adding. And obviously, I think that many of us, not all of us, but many of us, usually if we're going to give chronic continuous therapy, might not always add a CD20 monoclonal antibody in this setting. And certainly, I think, again, given COVID experience, that's something that you can plus or minus discuss with your patients. Sometimes I'll use it if I think somebody's got an immune-mediated, needs a quick turnaround in terms of a cytopenia that is more immune-mediated, needs a quick response, and then the BTK inhibitor can then, sort of handle the rest of it. But Jen, do you add a lot of CD20 monoclonal antibodies with your BTK inhibitors?
Yeah, I hardly ever do. And I mean, you're right, like the obinutuzumab data is much more robust than what we saw with rituximab and probably provides some benefit for some patients. But I agree. I think if the patient really wants that easy start, continuous therapy, adding a CD20 antibody sort of negates the benefit of doing the BTK inhibitor in the first place. So, until we find that there are specific groups of patients that benefit from it the most, I really haven't been doing it. The other thing I think would be helpful to discuss a little bit is we talked about how Nathan had unmutated IgHV. And I was just wondering, Nicole, what's your practice? Like, do you counsel patients differently, whether they have unmutated or mutated IgHV?
I mean, obviously, given the robust data that we have with the novel agents for, whether they're unmutated or not, as you said, they've become much better players. And so, even though patients really focus on their prognostic markers and are very dismayed when they find out that they're unmutated, certainly this data suggests that they're going to do very well with BTK inhibitors. And so, certainly, obviously, no chemoimmunotherapy for the unmutated is pretty much standard for my practice. But certainly, obviously the novel agents do really, really well. So I don't hesitate, separating that. I tell them how well they're going to do on a BTK inhibitor, despite the fact that they're unmutated.
Yeah, and I think, with the longer term follow-up from CLL14, it seems like there might be a hint of difference for those IgHV mutated versus unmutated patients, where those that are mutated are the ones that are maintaining their remission over many years, whereas we're seeing some relapses, after a couple years off drug in the patients with unmutated IgHV. So I certainly don't hesitate to give those patients that regimen, but I think that's something I'm going to be looking really closely at when we see longer and longer term follow-up.
Yeah, agreed. Absolutely. I think we need a little bit more follow-up to see if that's going to be a shift in the way we sequence when we talk about what's the right agent to start first, if it makes a difference, and what subgroups. Absolutely. So now let's take Nathan, same blood counts, adenopathy, and characteristics about his CLL. but we're going to change things about him. So he has now hypertension that is poorly controlled. So all the same discussions we had before, but now poorly controlled hypertension. So when we think about that, Jennifer, what would, what options, what might you consider a little differently now that you know that he is poorly controlled hypertension?
Yeah, so we saw from the head-to-head study that hypertension is much more common with ibrutinib than acalabrutinib. We've seen actually also in a number of retrospective studies that hypertension over time with ibrutinib is really, really common. Probably upwards of 60 to 70% of patients either need an antihypertensive added if they're not on one before, or need another one if they are already on an antihypertensive. So in this patient, unless there were reasons why they couldn't do other things, I would lean towards acalabrutinib rather than ibrutinib. You certainly could also consider just doing venetoclax obinutuzumab because there is no safety signal with hypertension in those patients. Whereas with acalabrutinib, though much less than ibrutinib, you still do see some hypertension.
I think that's really important. And of course, again, regardless of the BTK inhibitor that you choose, certainly to try to get their hypertension in good control regardless is important to work with their other physicians to do so. So acalabrutinib or venetoclax obinutuzumab, I think, are great options for this patient. And again, the supporting data being the Elevate relapse data as well as CLL14. Now, what happens, so let's switch his comorbidities a little bit. So he has hypertension and he has a pre-existing history or history of atrial fibrillation. So when we look at that in that patient, what other options or what would you consider to sort of define an option better?
Yeah, so again, while atrial fibrillation is less common with acalabrutinib or zanubrutinib than it is with ibrutinib, there is still a higher incidence of AFib in BTK inhibitor treated patients than in people who aren't treated with a BTK inhibitor. So I think, using a venetoclax-based regimen in this patient, all other things being equal, probably makes the most sense. If the patient didn't want the infusional component with the obinutuzumab or didn't want to come for the ramp up, I think you could consider using acalabrutinib. It's important to note, though, that the risk is still present, though less than with ibrutinib. I think with the Elevate RR study, we saw about a 9% risk of AFib, and it was higher in patients who had a history of AFib before.
Yeah, so really important, right? So you're talking about the potential of the side effects of these medications and still working with your patients. And certainly, so even though, characteristically we'll say you have a history of atrial fibrillation, let's move on to something like venetoclax. Certainly it could be more dicey. The patient may have some renal insufficiency or, like Jennifer noted, not want to come in for, the intravenous infusions. And then you're looking at maybe a second generation, but you're still going to tell your patient, there's still a potential risk of atrial fibrillation in that scenario. So, and again, this data supported here by the CLL14. And then now let's talk about a younger patient. Well, I guess if he was younger, I guess we moved away from Nathan being 73. If he was 56 years of age, and when we talk about options of therapy, if he preferred something that was once daily dosing, sort of more simplified treatment, I think this is a little easier. Jennifer, what would you say here?
Yeah, so I think the answer here is pretty clear. Ibrutinib is once daily versus acalabrutinib being twice daily. And I don't know about you, Nicole, but I think this is kind of an important thing to talk to patients about at the outset, is like the expectation that they have to take the pill twice a day if they're going to use acalabrutinib. And if they really don't think that that's something that they can manage, those patients should probably be on ibrutinib rather than acalabrutinib. We talked a lot earlier about what is better about the second generation BTK inhibitors, but we didn't spend any time talking about what might be better with ibrutinib. So certainly once daily dosing is nice with that drug. The other thing is the proton pump inhibitor contraindication with acalabrutinib. And then even if it's not a PPI, if they're on an H2 blocker, it has to be spaced out from the drug, which can be difficult with a twice daily drug. The patients are having to set a lot of alarms on their phones, in my experience, in order to get those drugs in effectively. So that's another place where either ibrutinib or zanubrutinib might be a good option. Are there any other places where you like to use ibrutinib?
Yeah, absolutely. I think that's a really good discussion point. We forget about the proton pump inhibitors or the other drug-drug interactions, and it's always important to go over all the medications of your patients. And certainly, obviously, a lot of the specialty pharmacies have a lot of pharmacists that help counsel as well. But it's always important because this comes up quite a bit. And so once daily dosing is a big deal for many patients and may choose to do so, or the spacing out bit depending upon if they're on a proton pump inhibitor. So absolutely, you can see preferences come out, and that's where oftentimes, absolutely preferentially, some of my patients will easily go on Ibrutinib versus twice daily dosing with acalabrutinib. So here again, some of that data being supported by ECOG 1912. And then we'll go to another case.
All right, so we're going to keep the same disease categories and keep the comorbid hypertension. Now, Nathan does go on single agent ibrutinib. He has a response and things are going really well. And then after 4 months, he develops an episode of AFib. So I think this is a huge question in clinical practice. Do you continue the ibrutinib? Do you dose reduce? Do you come off that medication entirely?
Yeah, so I mean, this is tricky because obviously it comes up common enough that we're learning how to co-manage atrial fibrillation along with the BTK inhibitors. And certainly, I think the reason why this is an important question is because I think a lot of folks automatically think that they're going to have to abandon BTK inhibitors altogether, and that's not necessarily the case. So I think it's important. Typically, I would usually stop the ibrutinib, get the atrial fibrillation under management, talk to the patient, of course, about this in terms of whether or not they would be willing to be re-challenged with a BTK inhibitor, and oftentimes switch them to a second generation BTK inhibitor in this case. I don't find that dose reduction necessarily helps. So I'm usually switching. If a patient, of course, tells me that because they've never been on any medicines whatsoever and don't want to deal with being on cardiac medicines or the potential of that happening again, then we'll discuss switching over usually to venetoclax-based therapy. But oftentimes I'm going to try to see if we can still maximize depending upon how they are.
Yeah, completely agree. And as you showed earlier, with both acalabrutinib and now zanubrutinib too, we have a lot of data for patients who are intolerant of ibrutinib for one reason or another, and AFib is one of those reasons that comes up a lot. And many of those patients, actually most of those patients who go on to a second generation inhibitor actually don't have the same toxicity occur again. I think before we had the second generation inhibitors widely available, we always used to just continue the ibrutinib at the same dose or dose reduce sometimes, manage the atrial fibrillation and continue on. And that's because those patients just really didn't have any other options at that time. But I think we're really lucky now that we do have these second generation inhibitors. One of the studies that we had done at Ohio State retrospectively is to look at ventricular arrhythmias with ibrutinib and try to see if we could find some predisposing factors in the patients. And the only thing that ever came out was patients who had previous AFib were more likely to have subsequent ventricular arrhythmias. So that's something that's really stuck with me, and one of the reasons why I almost always will just switch them to acalabrutinib if they have AFib on ibrutinib.
Yeah, fair enough. So I think it's important to note that you can still try to use these agents in somebody to maximize the class because they're such an effective treatment for our patients with CLL. But obviously, it's still in discussion because there are many patients, if they've already on hypertensive medications, don't have a problem having the cardiologist tweak their medicines and be treated and be switched over to second generation. Some of my younger folks who have never had this and then go back to a normal sinus rhythm are a little bit more on edge about going back to a BTK inhibitor because they really don't want to be on these extra medications. So sometimes that's a challenge, and then I might switch them over to venetoclax. I'm sure you find something similar.
Yeah, I absolutely agree. And I think we think of AFib as just, a toxicity like any other, but I think it's so different than any of the other toxicities we encounter on the BTK inhibitors because it comes with a whole slew of other medications and other issues. So like now the patient has to follow with a cardiologist too. Now they have to be on a blood thinner. Now they have to be on, either a RAGE or rhythm control agent. And I'm not sure about your experiences, but ours, or even if the patient's back in normal sinus rhythm, is on a different medication, a lot of times they have to stay on those medications. So I think, it's not just a toxicity that's at the time point it occurs. It's something that, the lasting effects will continue on.
Yeah, agreed. So I think that, and as you said earlier, when Ibrutinib was the only agent we had to salvage patients who are multiply relapsed from chemoimmunotherapy, we co-managed, and of course we did so to stay on, and so did the patients. And at that they weren't minding because they realized the severity of their disease and the little options they might have had subsequent to that. So, but now there are other options. But again, great class of drugs, and since we're thinking long term about going from one agent to another agent to another agent, for many of our CLL patients who might experience more than one therapy during their lifetime, it's great that we have some choices that we can choose from depending upon.
So here's our recommendation: would be sequencing to a second generation inhibitor based upon the current evidence. And as well, now we have evidence. We already talked about patients being treated with acalabrutinib or zanubrutinib in the BTK inhibitor intolerant setting. We also have that data that you showed earlier, Nicole, with pirtobrutinib in BTK inhibitor intolerant patients on the Bruin study, showing that with that selective reversible BTK inhibitor, most patients can go on and tolerate a BTK inhibitor class just fine if they're given pirtobrutinib rather than ibrutinib.
Okay, so for the case 5, which is our last case, so let's talk about now Nathan. So he initiated therapy with fixed duration venetoclax obinutuzumab, and he's responded well. He had some grade 3 neutropenia during his therapy, and remember, fixed duration in the frontline setting with CLL14 was 12 months of therapy in duration, as opposed to the Murano and relapse, which is 24 months. So he completed therapy and he's been monitored off therapy, and then he's noted to develop some progressive disease after 2 years off therapy. So when we consider options for therapy for him, after relapsing after venetoclax obinutuzumab, we have to consider what we're going to do next. And does his experience of neutropenia cater at all? Does it influence or change your subsequent therapeutic choices after this? Jennifer, what would you say to this?
Yeah, so this is a scenario where we don't have a lot of data right now for a really good reason, and that's that we have seen very few patients relapse after frontline venetoclax obinutuzumab. Most of the data that we actually have right now in the prospective setting comes from the Murano study, which you showed earlier, where we saw that patients after the 2-year regimen of venetoclax rituximab, when they were rechallenged or when they were challenged for the BTK inhibitor at the time of progression, had very high response rates and prolonged remission durations as far as we can tell. This was also seen in a retrospective study too. So, in this patient who experiences progressive disease after 2 years, so that's 1 year on therapy and 1 year off therapy, I probably wouldn't do venetoclax obinutuzumab again, just given the short remission duration. So I think switching to a BTK inhibitor is absolutely the right thing to do in this setting. Either ibrutinib or acalabrutinib would be great options, just kind of depending on comorbidities, patient preference, things like that. And then the other question is whether the neutropenia on venetoclax makes any difference for how we're going to choose our next therapy. And, as you've experienced as well, venetoclax is really common with, neutropenia is very common with venetoclax, especially during the ramp up, but in some patients persisting after that. And that's a toxicity that's pretty unique to venetoclax. And I don't know of any data that would suggest cross-reactivity with the BTK inhibitors. So I would probably go into it not even worrying about the grade 3 neutropenia from the previous treatment. Any different thoughts from you?
No, I'm in agreement. I guess the question I have, although it's again extrapolating from the Murano data, would be what would you feel comfortable when, after progressive disease from venetoclax-based regimen, given the data that we do have, that you would feel comfortable re-challenging? You said a year was too short. What about 2 years? Or would you, how long would you consider acceptable to re-challenge with either ven monotherapy or ven-based therapy again?
Yeah, great question. I'm interested in your thoughts as well. I think after the 1 year therapy, a treatment-free interval of at least 2 years is probably what the shortest I would take is a time to re-challenge. And it depends a little bit too on how they did with the venetoclax therapy. If the venetoclax was really well tolerated for them and they had 2 treatment-free years and they needed additional treatment, I might do venetoclax again, knowing that your remission is going to be shorter. But if they had any trouble with the venetoclax, I would probably do a BTK inhibitor then, just because if they had 2 treatment-free years before, I think the chances of even getting 1 treatment-free interval next time is pretty low.
And then maybe a stickier question. Yeah, I agree with you, absolutely. And I think we just need more data. But the Murano data was just so impressive, right? I mean, just if you think about the patients, it was 2 years in duration, so I understand that's different, but they were pre-treated, although only, I think, 1 median prior line of therapy in that study compared to some other studies. But with that being said, if you think about the median time, to the evidence of progressive disease, but not needing treatment was about 2 years, and then another 2 years that they might need treatment. So patients can buy 4+ years off of therapy, from the data that we saw with Murano. We now have pretty mature data at 5 years. What do you think about the upfront CLL14 data?
Yeah, I mean, I think. Yeah. Oh, go ahead.
Yeah, no, in terms of, durability in that sense. So, should we be expecting a longer response duration than what we're seeing, with the Murano study, for example?
Yeah, I think that's a great question, because I mean, right now we're at 4 years of follow-up and 74% of patients still in remission. So it's probably going to be, my guess is that it's going to have a fairly similar median duration of remission to what we're seeing with the BTK inhibitors, again, with 1 year of treatment and then the rest treatment-free. And then an additional, potentially year or 2 before they actually need treatment for their disease. So yeah, I think especially for those patients with good risk CLL, it's pretty tempting, as long as they're willing to do the infusions, to do the venetoclax Oben up front. What do you think?
Yeah, no. So I think it's really nice to see, albeit obviously a little bit immature data. I think it's going to be really nice to follow. And as you noted earlier with the patients who are unmutated, whether or not those curves wind up superimposing again, or we're going to see sort of a quicker relapse, a shorter response duration, and need to alternative therapies in those individuals. So very interesting, nice to have another agent that we can use for our CLL patients. So very good.
One other thing I think is going to be super helpful to see in the long-term follow-up is whether the sequence matters. So right now, I think all we can say is that, either sequence is effective, and we don't know which one is better. I mean, we know that BTK inhibitors are more effective when given in earlier lines of therapy. And whether the magic number there is 1 or less or 2 or less, it's a little bit hard to tell. And venetoclax, we just don't have quite as much data. You would expect that that's going to be true as well. But I think it's going to be really helpful in the follow-up of some of these big frontline studies to see what patients are getting next and how long of remission durations they get. Because, when we wait to do an actual sequential study, it's going to take 10 years.
Yeah. Absolutely. Absolutely true. And again, I think this, despite some of the data that will eventually mature over time, of course, in part, this is still going to be dependent on some of your patients' comorbidities and issues that they might have in choosing an agent, or being the circumstances of, what's going on with COVID. So certainly those will influence your decision regardless, because these therapies are so effective. So we're very fortunate. Okay. So let's get... So again, patient is BTK naive, so sequencing to a BTK inhibitor, a very optimal choice. Although we talked about the fact that you could potentially re-challenge with venetoclax depending upon the time off of therapy. Too short, probably not. Many of us favor switching altogether to a BTK inhibitor, but maybe a longer disease remission off therapy, a longer time off therapy, many of us would be encouraged to re-challenge with a venetoclax-based regimen. And so some of the supporting data, yes, I agree with Jennifer here. I don't think the neutropenia should impact his subsequent line of therapy with a BTK inhibitor. Very common to see neutropenia with venetoclax-based regimens. And so we just support patients. Sometimes you have to hold or dose reduce or growth factor support. But this wouldn't, I think none of us would worry or be concerned about doing a subsequent therapy with a BTK inhibitor in that circumstance. And then clearly you can see here that some of the data that we've amassed over time indicates that using BTK inhibitors post-ven in BTK naive patients is effective. We've shown that data. Again, if somebody is BTK resistant, I think that data, obviously, patients don't do as well to re-challenge them with a BTK inhibitor. So just some final take-homes from the case discussion that we had regarding Nathan. Obviously, for many patients, either a BTK inhibitor or venetoclax-based regimens are excellent choices. That sequencing data that Jennifer was talking about, hopefully we'll get that over time. Is there something that preferentially, should it be a BTK versus ven first, or is it patient-specific depending upon whether they're high risk? And so certainly we'll amass that data over time. Obviously, many of us feel that the TP53 abnormalities, we'd favor the use of the BTK inhibitor given the data that we currently have, although we'll see over time how that matures as well. And then again, when choosing among the many available BTK inhibitors and more to come, as we've discussed with zanubrutinib and non-covalent BTK inhibitors as well, you're going to consider the comorbidities, the adverse event profile, what your patients have, concomitant drug administration as well. Intolerance to one BTK inhibitor does not preclude use of a subsequent BTK inhibitor. So I think we showed some really nice data that you can go from one drug to another to try to obviously maximize the use of BTK inhibitors as a class overall. And then again, we've shown some data with the evidence supporting use of BTK inhibitors followed by ven-based therapy or vice versa. So I think we're having more mature data that if they start with venetoclax-based regimen, that certainly you can go on to use a BTK inhibitor subsequently and vice versa, giving the mature data that we have with BTK inhibitors in frontline therapy. So what's next for BTK inhibitors in CLL? Obviously, many of us, there's data which we didn't dive into, so we apologize given the time period, but obviously looking at oral combinations. So Captivate and the GLOW studies looking at ibrutinib and venetoclax, and you'll see calibrutinib and venetoclax studies, but obviously high rates of remission and MRD negativity, a change with oral combination, and obviously the advantage being fixed duration to oral agents. So we wait for obviously longer follow-up and data regarding some of these studies. And now there's also triplets as well. So looking at a BTK inhibitor plus a CD20 monoclonal antibody such as obinutuzumab and venetoclax. So you have a calibrutinib and zanubrutinib based studies, again, very with high responses. So we're looking to longer follow-up with some of the novel triplets. And then, of course, we're talking about some of the early data with the non-covalent BTK inhibitors such as pirtobrutinib and others that are coming down the pike that for patients developing some of the BTK C481S mutations and others, these will be a potential option, again, to salvage our patients. We know we can use venetoclax. Hopefully, we'll be able to go on to use these agents as well. And so we'll see how that fits into sequencing. So we received several questions that we're going to try to go through as many as we can in the time that we have allotted. And maybe, I'm sure Jennifer and I will probably digress and talk about other topics along the way that go along with these as we all think of questions that go along with some of these topics. But since COVID has been a big issue, obviously, for everybody in the last year and a half, and now we have a new Delta variant, well, not that new, and now we're dealing with newer variants that are coming along as well. I guess one of the questions that came was, are you reinstating any COVID-19 protocols that you had in place earlier favoring oral versus IV agents? Jen, you want to comment? I'm sure we both can comment.
Yeah, so I guess I would start by saying I don't know that we actually backed down on a lot of the COVID changes we made, because even with the case numbers low and even with the vaccines, we know unfortunately our CLL patients don't respond as well to the vaccines as people without CLL. And the patients who were on any type of treatment had very low antibody production after COVID vaccination. So though the Delta variant certainly heightens some of the awareness, I've been favoring oral agents for the most part. There also is a lot of observational level data that looks like patients treated with BTK inhibitors may be doing better with COVID than CLL patients that aren't being treated with BTK inhibitors, and some speculation that the anti-inflammatory effects might be beneficial. Certainly I wouldn't mandate that a patient choose the BTK inhibitor or over venetoclax obinutuzumab, but I think there's a lot of things to consider during the COVID-19 times. What's been your experience?
Yeah, I mean, I think part of this, for sure, I think regionally, depending upon the circumstances in your area, you might be, backing down or off of your intravenous agents, depending upon what's going on. I'm in New York, actually, and right now things at the hospital level have been very good so far, but we're anticipating that obviously things will get worse. I mean, the fortunate thing is that most of the patients that we have currently in the hospital haven't been vaccinated and are not the folks who have been vaccinated. But we know, as Jennifer noted, that our CLL patients certainly do not mount the robust antibody response, and that's something we're going to be learning over time. I would encourage all your patients to get vaccinated. I would encourage them to get their booster, and then there are clinical trials that are ongoing to look at patients with CLL or other immunocompromised immune conditions in terms of how to support them better and what things to use. I think it's also important to note that the Regeneron antibody cocktail is available for patients. And so it's something that we've been doing. Jennifer, I'm sure you probably have as well. So for patients, if they have obviously have COVID and, are diagnosed, and within a certain time period, it's an infusion that they can get that's about an hour. And certainly we do encourage our patients to come in and get that infusion as well, hoping that we decrease the severity of their illness and keep them out of the hospital. So I think that's important. So I think that many, if patients are on venetoclax and they're getting a monoclonal antibody, many of us have held the monoclonal antibody but continue their venetoclax. So it's not that I'm preferentially switching people, as Jen noted, to a BTK inhibitor because of that. But certainly when you're talking about start introducing new treatment options for patients, this is what Jennifer was referring to. Many of us might, say this is what we have currently with our data, although obviously there's a lot we still don't know yet. I think that's fair, right?
Yep.
So let's talk a little bit about, do you think, and we'll talk about triplets in a variety of different ways. I'll start off with at the top of the questions. Do you think that triplets might be potentially curative in the frontline setting? And what about the toxicities that are associated with the triplets?
I think, it's such an interesting question. And I don't think anybody knows the answer right now. It's so tempting to think that there may be a subset of patients who are going to either be cured of their disease or functionally cured. I mean, if they're older and we give them a 15-year remission duration, if these work really great, there may be patients who don't ever need to think of their disease again. But I think it's just really too early to say. I think our study at OSU, which was Ibrutinib, venetoclax, obinutuzumab, has the longest follow-up. This was published by Carrie Rogers earlier this year, and at 3 years median follow-up after completion of a year of therapy, actually no patient in the frontline setting had relapsed out of 25, and 2 patients in the relapsed refractory group. Now, again, it's a very small study, but I think that it is encouraging that there are some patients who are getting very long remission durations after this. What about you? Do you think any of these patients are cured?
No, I think it's fair. When we look at the different, when we look at our more favorable patient characteristics and how well they did with chemoimmunotherapy or certain treatment options, I think that for sure that obviously very effective treatments combined together may give those individuals a much, a longer time off of therapy and potentially curative, just as you said. Now, whether or not all patients need triplet combinations is, whether they need that, and there obviously is increased toxicity, albeit you're truncating therapy, right? So you're giving it to them for a shorter period of time. So if you can get them through that therapy, certainly it has its benefits. And this is no different when we look at venetoclax obinutuzumab, right? Much more labor intensive up front. But if you get them through that year off therapy, again, then they go back on monitoring. So there's no doubt that there's some increased toxicities when you combine doublets, triplets together, but the added benefit, and hopefully we'll see more mature data over time where that might be more, to which patients that might be more beneficial. So I think you're right, only time will tell. Now, what about MRD status? I guess we didn't really talk a lot about MRD. First of all, obviously that's been more championed with venetoclax-based regimens, but certainly can we use that in BTK-based therapy, or can we look at that? Obviously Ibrutinib being the first to market and as a chronic continuous therapy, we've seen data, right, from the Resonate-2 data, the more mature data, that more patients are getting complete remissions the longer they're on therapy. Could some of those patients be MRD negative now? So what do you think about that, Jennifer?
Yeah, I think it's going to be a long time before we have any data to justify that approach, just because, especially when you're talking about a single agent BTK inhibitor, so few patients become MRD negative, even if you follow them for long periods of time, even if their counts are perfect. A lot of times on flow, especially if you do it in the bone marrow or clonoSEQ, you're likely to see some residual disease. Now, I don't think, though, that means that you can't successfully stop a BTK inhibitor in anybody. We know from the ECOG study of ibrutinib rituximab versus FCR. So they looked at patients who came off of the ibrutinib therapy for reasons other than progression and found a median of 2 years to progression off therapy. We looked at that as well in Alliance and found that it was particularly dependent on how long they were on treatment before. But if you had people who were on treatment for longer than a year, they could get really long remission durations without any treatment. And I think that the same is likely true if you have somebody who's on treatment for 5 years and has an MRD negative complete response. Probably if you stop it, you can go a number of years before restarting it. And probably if they have disease that comes back, you could start a BTK inhibitor at that point again. Certainly completely data-free, but it probably would work. Have you ever done that in your practice?
Yeah, I mean, there are many of my patients, particularly my younger patients, right, who, prior to venetoclax being available, are going, well, can we do this now, with the BTK inhibitors? Can I stop therapy? And certainly we have that discussion and a treatment evaluation to see where they are at. And I guess that brings up the bigger question about MRD in general, even with venetoclax. So if you have somebody who's gotten CLL14 up front or Murano in relapse and still has MRD but are in a complete remission, are you still stopping their therapy?
So I do now, just because there are some studies that are looking at that that may or may not completely answer the question. But I think right now, with the venetoclax-based regimens, we don't have a lot of data to say that like continuing on therapy, that you get a lot more bang for your buck if you did another 6 months or a year of venetoclax. Certainly some people do it, and I don't think that that's the wrong thing to do. I think, again, we just don't have a lot of data to say how much benefit you get from that.
Yeah, it would be nice. I mean, as you noted with the studies you just talked about with regards to ibrutinib, that some individuals who came off for different reasons, still their response lasted over time. And so it's not to say that we couldn't do this with BTK inhibitor-based therapy. Like you said, it's just that we don't have the data that we do in the venetoclax trials. But certainly I think that many of our patients would like that kind of data, because they might be able to stop therapy and go many years for being re-challenged where they have progressive disease and need a new agent, and whether that be they switch to venetoclax or similar to what we're doing with the venetoclax, can we go back and re-challenge them on a BTK inhibitor? And so certainly I think that's obviously very possible.
And you guys probably are looking into this as well, but one of the things we've been interested in from a trial perspective is, can you add something to a BTK inhibitor at a later time point and get those patients who have partial responses or MRD positive responses and actually drive them into an undetectable MRD and then stop therapy? To me, that's a really appealing way to do it, because you have, something that what you're doing might help, and you have something tangible to measure. But again, certainly that's clinical trial.
Absolutely agreed. Absolutely agreed. And then I think we've answered this earlier, but I think we'll just readdress this. What is your preferred BTK inhibitor in older populations with 2 or 3 or more comorbidities?
So in the absence of a clinical trial, because I think either ibrutinib or acalabrutinib is certainly an appropriate therapy. And if a clinical trial was using one or the other, I'd have no hesitation to do that. But in the absence of a trial, I would choose acalabrutinib for older patients, especially those with comorbidities, just because of the better tolerability overall. And specifically, we know that AFib is a higher risk in older patients. So for those people, I think that the risk of AFib gets progressively higher the longer they're on drug, and I would choose acalabrutinib.
Yeah, I think obviously the patients who have been on ibrutinib and tolerating it well, I wouldn't even I wouldn't consider even switching them
Yeah,
over.
absolutely.
But certainly for patients who have more than one comorbidity, particularly if they have cardiac issues, I'm generally switching them to second generation. And then I guess that segues into one of the questions as well. So if zanubrutinib gets approved soon for CLL, how do you choose between the two second generation BTK inhibitors, acalabrutinib versus zanubrutinib?
I think that's such a good question. And I don't know about you, but I don't have a lot of experience with zanubrutinib just because most of the trials that have been done so far were done outside the United States. So I think there's not a lot of the trials that were done in the United States and the approvals are in diseases other than CLL. So I've only used it a few times, but I had good experiences. And I don't know which one I would choose, to be honest. I think, certainly the patients who have a proton pump inhibitor or other contraindications to acalabrutinib, then it's an easy choice for zanubrutinib. So far, the data looks like there might be a little bit lower risk of AFib even with the zanubrutinib than acalabrutinib, although that Alpine data suggests that maybe the hypertension risk with zanubrutinib is a little bit higher. So it's a little bit confusing. I'll probably stick with acalabrutinib initially just because I have used it more, but I think zanubrutinib is a great drug too. How about you?
I think that's totally fair. I do have some of the zanubrutinib studies in CLL, and so I have, although less experience compared to the other BTK inhibitors, but certainly the patients on zanubrutinib are doing extremely well as well. I think it's more difficult when you're trying to split hairs and choose between them till we see more mature data. Obviously, the data that you presented with the head-to-head data with ibrutinib and ibrutinib and zanubrutinib will be nice to see. Is that overall response, is that going to translate into something over time or not? That'll be persistent. But obviously when you're talking about the adverse events, both had really nice decrease in the frequency of those events. And so I would have no hesitancy using either. But if they have a PPI, I think it's easy to select for things like that, or if there are drug interactions for sure. Okay, and then I think, again, just to go over, given the Elevate data, are you adding obinutuzumab to acalabrutinib? I think we answered this pretty succinctly. I think many of us are thinking chronic continuous BTK inhibitor-based therapy. Many of us are not necessarily. I am not adding obinutuzumab to acalabrutinib at this point in time. That sort of, in my head, as Jennifer had noted earlier, sort of defeats the purpose if I'm thinking chronic continuous therapy, unless there's a specific reason that I might want to add it. As I said, maybe somebody's got ITP and their platelets are 20 and I'm nervous about starting the BTA. I might front load them a little bit with an antibody and then get their counts up and add the BTK inhibitor. But other than that, I think I'd like the data from Elevate-TN is very nice. And I think I'm just going to want more follow-up to see whether or not it translates into something that's significant over time for our patients to do that. Otherwise, I'm continuing BTK monotherapy. What do you think, Jennifer? I think that's pretty.
Yep, completely agree.
And then arthralgias. I don't know, Jennifer. I always find that a challenge, unless it's such short-lived in the beginning, and then I don't have to deal with it. But yeah, there are patients who develop it later where it really is a challenge. Do you have any tips for how to deal with that?
I agree. To me, that is the most challenging side effect with ibrutinib. The couple of things that I hear from patients a lot is like hydration really makes a difference, and people who hydrate more tend to have less arthralgias. Some people swear by some of those things like mustard or pickle juice, though it's hard to really have a clinical trial seeing whether those are effective. The other thing that does help is steroids, because I think there probably is some like immune component to this, the arthralgias people get. So I will usually do like 20 milligrams of prednisone for a week and then step it down to 10 milligrams of prednisone and then try to come off of it. With some patients, that has worked beautifully and they've never had arthralgias again with the Btk inhibitor. Sometimes it works for a while and then comes back. And, in some cases, I am switching from ibrutinib to acalabrutinib or zanubrutinib for arthralgias. How about you? Do you have any other tricks?
I think that's exactly the case. I've tried, for some of them, I think these anecdotal things and steroids do work. But the others that no matter what you do, it doesn't. And then here's the perfect scenario of me switching to a second generation and trying, if they're, despite what we did, it, persists, or it comes back, once they're tapered off steroids, I'll try to switch them and see. And for some of them that has worked beautifully, and others, unfortunately, I've had to switch therapy, unfortunately, but that's much more of a challenge, I think, for sure. And then let's see, when would you retreat with BTKs versus switching to a Bcl2 inhibitor? And I think we kind of said that scenario. So if somebody has an intolerance, both Jennifer and I really advocated for switching to a second generation BTK inhibitor to try to maximize the efficacy, particularly if they're responding so well to a BTK inhibitor. But certainly if the adverse event, despite switching, isn't working, or if they're resistant. Now, maybe we can switch the question a little bit. We can ad lib here. So Jennifer, what if they develop resistance on a BTK inhibitor, but their counts are otherwise, it's sort of slow progression? So that, maybe their white count's going up, but their counts are otherwise fine. They're completely asymptomatic, or maybe you have some small little return of lymphadenopathy.
So this happens all the time. And I think it's really challenging because everybody's a little bit different in how long it's going to take them to really clinically progress. The one caution I would say, though, is most times people will slow, and then very quickly progress at some point. So you don't want to miss that window and actually get to the point where they're having very symptomatic progression. So usually, I'll watch somebody's white count for a few months, maybe even 6 to 12 months, if that's the only thing that's changing and it's not going very high. Once I start to see some residual or new lymphadenopathy on exam for sure, or CT scans, if we're really starting to see things get larger, I switch at that point. And I think it's probably important to note, just in case anybody is not aware of this, you cannot switch from one BTK inhibitor to another in the case of resistance, because all of the covalent BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, have the exact same mechanism. So if somebody's resistant to one, they're resistant to all those. And if you want to keep with the BTK inhibitor class, you really have to switch to the non-covalent ones like pirtobrutinib.
Yep. So that's a good example of that. And I think when people ask about sequencing, although obviously they're not yet approved, that might be another option, right? To switch from a covalent to a non-covalent BTK inhibitor in that setting. Now, Jennifer, with that, would you, just so people know, would you stop though because they're developing some evidence of their white count? Let's say, like you said, you'll monitor, but you keep people on their therapy. Is that correct?
Yeah, absolutely. I think that's like it's really tempting to want to stop therapy because you think it's not helping, but you always want to stay on the BTK inhibitor until you switch to something different if somebody is progressing.
And that's what I just wanted to make sure that take home point was there, because obviously not all of their cells are resistant. So they were still benefiting from the agent that they're on, albeit, that some of the cells are developing resistance. And so you might see that white count going up, but the majority, we would keep our patients on the therapy until you're ready to switch them to an alternative therapy at that point. So one final question before we close. So certainly, is there evidence to suggest that venetoclax can resensitize patients to BTK inhibitors after earlier progression on a BTK inhibitor?
So, what we know for sure is that if somebody has a C41S mutation and then you switch them to venetoclax, when their disease comes back on venetoclax, they almost always will still have that mutation present. So I think it's unlikely that you're going to be able to resensitize somebody fully to a BTK inhibitor after venetoclax. I don't know what happens in people who don't have a mutation, whether there may be resensitization for some patients. One thing that has been seen anecdotally, though, is occasionally if you have somebody who's relapsing on venetoclax after having been on a BTK inhibitor, you sometimes can add the ibrutinib back into the venetoclax to get at least a short-term remission while you're kind of thinking of your next step.
Yeah, I think this is important to note, although albeit really immature data, there might be, and obviously for these patients, who have relapsed on a BTK inhibitor and now also relapsing on venetoclax, whether you're adding it in and trying to get a little bit additive effect, you're going to be thinking of an alternative strategies for these patients because the response duration probably won't be so long. So then you're looking at cellular therapies or other clinical trials or novel therapies for these individuals, depending upon their comorbidities and circumstances, because obviously having progression for both BTK and Ven is challenging in our patients. So I think that's pretty fair to say, right, Jennifer?
Yep, I agree.
Okay. So finishing up, just to summarize, and that was awesome. The questions were excellent. Jennifer, thank you so much for doing this with me. Always a pleasure to talk with you. Thank you and good day.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/QZB860. This activity is supported by an independent educational grant from AstraZeneca.